I'm Dr. Mila Brujic, and today we're joined by Dr. Jeff Banas, where he's going to be talking about interventional optometry on the OI show. Welcome, Dr. Banas, and thank you so much for being on the show. Give us a little bit of background on yourself, what you do on a daily basis in the office, and really your areas of passion and practice.
Sure. Well, Dr. Brujic, number one, it's an absolute privilege to be here today. Thank you for having me and thank you for allowing me to, share my passion with you. I am the senior and lead optometrist at the Eye Centers of Racine and Kenosha in southeastern Wisconsin. I specialize in glaucoma management, but we do a little bit of everything here. I do a lot of cataract refractive surgery, pre and post-operative management, a lot of dry eye, as well with those two main subspecialties of mine. But we like to dabble in a little bit of everything. We are led by a world-renowned glaucoma specialist, Paul Singh. So, we revolve around the glaucoma world for sure. But we're a general ophthalmology clinic, and that, has been in the community and the industry for, at least 45 years. We service southeastern Wisconsin heavily here, but we have people from, all over the world that fly in to see us and work with us. So we're very blessed to be trusted with, a number of patient care, a number of care from a number of patients around the world. And I love what I do. I absolutely love what I do. So, but yeah, glaucoma is my main focus and my main specialty.
So, Jeff, what's your role in the practice then? If glaucoma care is it, I mean, I'm assuming you're probably doing ordering, interpreting all the diagnostic tests. And what's the scope of practice in Wisconsin for you? Like, what can you and what can't you do?
It's full scope. I mean, we have the ability to do lasers. There are optometrists in Wisconsin that are practicing lasers. I don't practice lasers myself in our clinic, just with, the glaucoma specialist that we have in house. We just leave it to him to do his thing. But me primarily, I'm managing the clinic day to day. I'm the front line. I deal with a lot of the, initial diagnosis, initial management, continued management throughout that, life cycle of the patient, and then I will refer for surgery, and then handle that care post-operatively, and then manage, indefinitely going from there unless I need to get back to my surgeon.
So you're kind of making the decision, you're monitoring the patient, you're doing maybe traditional medication therapies or topical therapies, and then you're saying, really now it's the time to think about surgical intervention, and that's where you would send to the glaucoma specialist within the practice, correct?
Correct, yeah. But I also do make a lot of the recommendations, we'll say, for what surgical options to consider with, what I'm sending them for.
So that's what I want to kind of dig into a little bit deeper here, Jeff, because this term interventional glaucoma management has been this thing now that the profession's been talking about for the last several years. Give us a little bit of insight around this and what this really means on the ground floor in clinical practice.
Yeah, so, to me, interventional glaucoma is a paradigm shift from, where we were, we'll say, classically trained. I'll refer to it going here on out as the legacy paradigm, where, we're trained to diagnose somebody with, say, ocular hypertension, glaucoma, and we typically start with an eye drop. Usually most of our colleagues are going with a PGA. And then if things progress for any reason over time, they are escalating that, in some form of pharmaceutical therapy, and adding more drops. In the interventional glaucoma world, it's not about, escalating those drops. It's more about thinking about quality of life with the patient, acting sooner, and looking at a more focus with things like procedurals. So, SLT, for instance, as a first line therapy,
Yeah.
escalating that to intracameral drug delivery, and then escalating that to things like MIGS or MIBS, minimally invasive bleb surgeries, and then eventually, larger outflow tubes potentially if needed. But it's not just surgical. I think we need to, kind of dispel some of the myth around that. Sure, we have some of these procedures like SLT, and I mentioned, intracameral drug delivery, but there is still a place for eye drops. It's not going to eliminate eye drops. Eye drops are still within the continuum of all this, but we have a lot better options nowadays to help improve a patient's quality of life by trying to reduce that drop burden and improve compliance and ultimately, preserve patient's optic nerve for decades, as opposed to, what other eye drops can I add, and then potentially progressing from things like non-compliance.
So it almost sounds like intervention is a mindset in terms of the way that you're tackling this. I know that, geez, Jeff, this is now 25 years ago when I was in optometry school and then just graduating. And I remember we were always kind of debating whether or not we saw damage before we would start treatment. And I'm assuming interventional glaucoma is really this mindset shift where, wait a second, you don't have to have a certain amount of damage before you start treating. And ideally, you want to treat before you see damage. Am I way off with that?
No, you're 100% right about this. When you think, I like to think of glaucoma as a boulder kind of rolling down the hill, right? It's much harder to stop that boulder when we're at the, end of that hill as opposed to kind of earlier intervention and getting up there and intervening sooner. So for me, especially in the clinic that I'm in, we will act at, even the slightest hint of something. I don't wait for RNFL damage. I don't wait for functional, vision loss. I look for signs that, even though everything might look good, that we have, maybe even a genetic test that increases your risk for developing glaucoma long term. We have newer tools nowadays. For instance, the Ocumet beacon is something that I am very excited about. That think of it as a autofluorescence camera that allows us to see stressed out mitochondria and see how they are doing in comparison to somebody that might not have any of this kind of glaucoma suspicion. And that can increase our suspicion for, or need to treat earlier. So, we're looking for reasons really to improve, like I said, improve that patient's quality of life and preserve that nerve for decades as opposed to waiting to see damage for sure.
So Jeff, take me through a little bit of the logic on how it works in your office, because it's got to be exciting to work with this level of technology on a day-to-day basis. But
Yeah.
I walk into your practice, you feel that treatment is appropriate for me to get started. Will you
Mhm.
immediately bring up the concept of, and assuming that I'm a candidate for SLT, either SLT or a drop for me as a patient?
Yeah, I mean, I'm a big fan of SLT as a first line therapy. This is a procedure that's not actually altering tissue, and there's a lot of data out there now that supports that, whether that be something like the LIGHT trial that, many of us are familiar with, or a
Yep.
new consensus protocol that was released by, some of our colleagues to show SLT as a great first line therapy. Some of the newer technologies such as the DSLT make it a lot quicker. It takes out a lot of the, technical side of it in terms that might be a barrier for access for patients and providers from doing. And the data, supports it in terms of the IOP management over time. So for me, say you're an ocular hypertensive patient and I'm concerned about you, and even though everything else is looking good, I will 100% have a conversation with you about SLT. We'll still give you, an option if you want to try something like an eye drop, but I'm generally, anti-drops as a first line defense there, because I don't see a downside really to starting with SLT as first line. I'll give you your options and I'll tell you what, I will do. But I'm a huge proponent for SLT first line there.
Well, the presbyopic aging eye is definitely a frail eye. And
Yeah.
whenever we introduce something to the ocular surface, we have a chance of reducing the viability of the health of everything that's occurring on the surface of the eye, in particular when we're committing to something that's chronic. And the reality is if something's just starting, or if you're an ocular hypertensive patient, you're asymptomatic. So you don't feel anything, and now you're taking a drop that can potentially be causing these symptoms. So I
Yeah.
love the idea. I love the philosophy on all of this. Give us a little bit of insight into some of the advances in the micro-invasive glaucoma surgeries.
Well, we have a number of things besides SLT and DSLT now as, newer technology in the SLT space. We also have intracameral, drug delivery, whether that be biodegradable pellets such as Durista, for example. iDose is another thing that comes to mind that I'm a big fan of as well. But then when you think about, microtrabecular bypass stents, you have things like the iStent itself, the iStent Infinite particularly. You have Hydrus microstent, all kinds of minimally invasive stents that can bypass the TM, get better access to Schlemm's canal. We also have laser procedures now that I'm super excited about. The VLACE particularly. This is essentially a laser that's going to create a small channel through the TM
Hmm.
and It can be done in all four quadrants. It gives us a great view of the angle, and it doesn't require any incisions whatsoever. And the data, that is being studied on it so far is very promising. So I'm super excited to have that in clinic and see, how that employs. But this is like, a true lunge laser where we can dock somebody in this instrument like a LASIK and just, make a few channels in the TM and then go from there. So think of something like SLT and then do something like this via lace with a an intracameral device as well. You can even get even farther. You can get in there with canaloplasties, and there are a number of different canaloplasty devices that really are more ergonomic for our surgeons that allow them to perform that canaloplasty better. From something like the eye track comes to mind, goniotomies as well, and then eventually up to something like the Zen microstent, or sorry, just the Zen gel stent, something that's really effective in lowering pressure quickly from higher pressures to, say the upper single digits. So we have a lot of toys and a lot of options that are available to us nowadays, that are really, there's no reason not to be able to get to or we shouldn't be able to get a patient to a target pressure. We have a lot of, options to us now that still don't disrupt the ocular anatomy too much, and limits the amount of scarring and preserves options for our surgeons, long term if we need even more treatment escalation down the line there.
Jeff, so when you're thinking about the non-laser surgical options for glaucoma, are you
Mhm.
typically reserving those in combination with cataract surgery, or are you doing those even if the patient isn't needing cataract surgery?
Well, a number of these can be done standalone now. I ultimately leave that up to my surgeon to decide what's appropriate in those situations. But yeah, when I see a patient that might be an ocular hypertensive, they've got a cataract, I try to kill two birds with one stone, so to speak. I'll say, hey, I'll have that initial discussion with them. I'll say, look, you've got this cataract. And we were part of a study here at this clinic that had shown, removing a cataract alone will reduce eye pressure, but combining it with something like an eye dose gives us even greater efficacy in doing that. So, hey, I'm concerned about your eye pressure. Your eye pressure might be borderline or elevated. You have a cataract that's limiting your vision. You've got all these ocular surface issues going on. Let's treat the ocular surface. Let's avoid these eye drops so that we don't make that worse. And let's take care of that cataract at the same time and, nip your pressures there for you too. And then that way we can, have you sustained long term, have that drug concentrated to the anterior chamber and to those tissues that, we want it, as opposed to, all around there and causing, conjunctival and periorbital changes, and maintain that vision, that quality of life. And then that patient doesn't have to worry about, further utilizing eye drops if we keep the disease state controlled that way.
Jeff, so have you personally seen like these individuals that are then maybe potentially even referred into your practice? They're using drops and they have a conversation with the individual who's managing them outside of your office, and they say, well, you really need to see this group because they can talk to you about potential surgical options that may reduce your dependency on some of the drops that you're using. And you go through that procedure and you do those procedures. Do you find ocular surface improvement when you get an opportunity to remove some of these drops with some of these
Yeah.
micro-invasive glaucoma surgeries?
100%. I mean, and even if they're referred to us just for management and maybe not even a surgical option, I'm looking for reasons to remove drops on patients for that reason. I mean, not only the ocular surface, but me personally, I'm gonna say this. I don't believe everybody's 100% compliant. I don't care what my patients tell me.
Right.
They're gonna tell you, yeah, I use my drop. You know what? Life gets in the way. You miss drops. The pharmacy doesn't fill drops. You forget. You fall asleep in your chair. You're gonna miss drops. You're not taking them 365 days of the year. And when you think about, even just one drop, something like a PGA where that patient's taken one drop at night and we'll say both eyes, that's 14 drops per week. And then if you're escalating that on top of it to a combination therapy, now you just went up from, one drop a night to three drops a day. You just, tripled the amount of drops that they're taking. They're going to miss. The odds are in their favor that they're going to miss. And if they're missing their drops, their pressure is fluctuating, throughout the day. And if their pressure is fluctuating, so is their optic nerve health. There's data that's supported, it's not just higher eye pressure, it's also stability of that eye pressure. So I look for reasons to help keep that patient more stable and keep that patient more compliant. And that's where the interventional glaucoma mindset really works in the OD's, world. And I don't think we need to look at it as something that, is going to remove our scope of care, especially as we advance in states with things like laser, treatment there. But it's a trust builder for our patients. It's a way to just, better take care of our patients and preserve their vision for a longer period of time. I think if you really believe in that, then you're going to be looking at that interventional mindset. And again, it's not to say you're not going to use drops. There are many patients that still have these procedures that still need, one or two drops post-surgery. But I'm initially looking for reasons to get as many of those drops off of you as possible so that you have a better chance of, preserving that optic nerve function long term.
I couldn't agree with you more, Jeff. I think that compliance, even for symptomatic conditions, is low. And now you're
Yep.
talking about for some of these individuals, it's an asymptomatic condition. And you're, again, increasingly complex drop regimens can get difficult for these patients. And I'll tell you, Jeff, some of my favorite patients to manage are those individuals who have had some form of glaucoma surgery because all we're simply doing is monitoring them, and I don't have to have the drop conversation. That drop and compliance conversation just eats up a lot of time, not only for the technicians, but also for us, because you have to remember the color of the bottle, the top of the bottle. Is the patient remembering what they're doing correctly? Because oftentimes these individuals are in an aging population where they have a lot of things that they're managing. So it just gets
Yeah.
difficult. So I love,
Well, think
I love that we
think about the
remove the
chair.
barrier.
Sorry
What's
about.
that?
Think about the chair time as well. I mean, we did a little study in clinic too, and think about PAs and authorizations and the callbacks that you had mentioned. Anytime you prescribe a medication, you're dealing with all that on the back end, and that can be a barrier for our colleagues just to even want to consider utilizing an eye drop. If
Yeah.
you're a private practice owner out there, think about yeah, now I'm paying somebody to get your medication to you. That's not a good sell, at the end of the day. And I don't want to say sell, but it's not it's another barrier to access of care. So if I can just remove all of that, we've streamlined our process for those patients in the office. They're going to be quicker, it's going to be more efficient, they're going to be better controlled, they're going to be happier, and we're going to be doing our jobs more effectively and more efficiently. So to me, it's a no-brainer. It's a win-win.
Well, Jeff, this was awesome. Thank you. You've shed a lot of light on this topic, as I knew you were going to. We appreciate you so much, and thank you for taking time to be on the show, Jeff.
It's been an absolute privilege, Amelia. Thanks for having me.
And thank you all for joining us on this episode of The OI Show.